to talk about heart-lung interaction. My name is Ryota Sato. Thank you for introduction, Dr. Daoud. My background is, I did an emergency training back in Japan, and then I medicine trained, and then also critical care medicine trained. So I'm currently working with the intensivist at Queens Medical Center in Honolulu. So it's a nearby hospital. So today I'm going to talk about heart-lung interaction. And obviously this is very complicated topic and it's really difficult to understand. So I'm going to just overview the basics of heart-lung interaction. So nothing to disclose. So first of all, the reason why we're learning this is it's very important to understand what the interaction between heart and lungs, especially for the clinical decision making. And then the aim of this presentation is to help everybody to understand what's the interaction under negative pressure ventilation and also positive pressure ventilation. So history of heart-lung interaction actually started a long time ago, 7 years ago. Dr. Andre Conard, who is a pulmonary physiologist at University of Columbia, actually discovered cardiac catheters, and actually he measured a bunch of pressures inside of the ventricles and atrium. And eventually he noticed, oh, this is very useful to understand interaction between pulmonary and heart. So because of this discovery, later on, he was awarded for the Nobel Prize in 1956. But this does actually, this opens the door to understand heart and lung interaction. So when we talk about heart-lung interaction, there are two interactions mainly. So RV and lung, or LV and lung. So today I'm going to divide heart-lung interaction into two categories, RV and lung interactions, and also LV lung interactions. The first thing that I'm going to talk about is the RV lung interaction. So before going into the interaction itself, we have to think about what the venous system is. And for RV, the preload is RV and diastolic wall stress. So in normal heart, because RV system is a highly compliant, low pressure system, RV and diastolic volume varies very widely without changing RV pressure. This is a normal heart. And then pressure gradient for venous return is defined as a gradient between RA pressure and mean systemic pressure. Here, mean systemic pressure is basically mean pressure when there's no blood flow. So when you imagine vascular system is all just one closed system, there's no blood flow, then just by existence of blood in the circuit, there is a pressure, and that's a mean systemic pressure. So the pressure gradient between right atrium pressure and mean systemic pressure is the pressure gradient for the venous return. And that's the pressure creating the venous return. And the respiratory cycle doesn't affect the mean systemic pressure here. However, respiratory cycle affects right atrial pressure. And as a result, respiratory cycles affect venous pressure gradient for the venous return. And that's how respiratory cycles alters venous return. So there's one more notion, and that's a transmural pressure. So this is a pressure gradient between right atrium. And especially when there's no tamponade physiology, this applies to pressure gradient between right atrial pressure and pleural pressure. Now, of course, if there is a tamponade physiology, this is a different story. But in normal people, most of the time, transmural pressure is basically between pressure of the right atrium and pleural pressure. So here, this study was done by Dr. Pinsky back in 1984. So the left side is negative pressure ventilation. The right side is a positive pressure ventilation. So when negative pressure happens, as you can see, the right atrial pressure goes down. And then pleural pressure also goes down. On the other hand, transmural pressure goes up. As you can see, pulmonary artery flow goes up, and then stroke volume or RV goes up. So in the negative pressure ventilation, when inspiration happens, RA pressure goes down, blood pressure goes down, and then stroke volume goes up. On the other hand, when positive pressure happening, during the inspiration, RA pressure goes up, and air pressure, of course, goes up. And transmural pressure of the RA actually goes down a little bit. As a result, stroke volume actually goes down. So in between negative pressure ventilation and positive pressure ventilation, opposite consequence happen. So this is something we have to remember. So just in summary, negative pressure ventilation, during the inspiration, stroke volume goes up. And then positive pressure ventilation, stroke volume goes down during the inspiration. So here, we also have to talk about pulmonary vascular resistance, because this was talking about preload for the RB. And then mostly this is important for somebody who has normal lungs. But when we talk about somebody with acute lung injury, it's important to think about pulmonary vascular resistance. The pulmonary vascular resistance can be altered by these two mechanisms mainly. One is hypoxic vasoconstriction. Now, the other one is the mechanical vascular compression. So the pulmonary vasculature is usually actively dilating. So it's an active motion using energy. So usually the pulmonary endothelium is releasing the nitric oxide, and that's actively dilating the pulmonary vessels. So that's actually the mechanism of vascular dilation on the pulmonary. However, when oxygen is decreased and patient is hypoxic or acidotic, endothelium actually doesn't release the nitric oxide as much. As a result, in the setting of hypoxia, blood vessels actually gets tighter, and that's going to cause hypoxic vasoconstriction. The other one is the mechanical vascular compression. I'm going to take a look at this. So when you think about the pulmonary vascular venous pressure, there are two components. The one is alveolar blood vessels, and then the other one is extra alveolar blood vessels. So when you think about these vessels' resistance, outside of the alveoli, when lung inflates, because distance between each alveoli gets shorter, eventually the diameter of the vessels gets bigger and the resistance goes down. On the other hand, alveolar blood vessels, that's the vessels around the alveoli, because the alveoli gets bigger, it's stretched, and then resistance goes up. So total pulmonary venous pressure is a summation of these two pressures. And then that's a U-shaped curve. So the lowest pulmonary venous pressure is achieved at functional residual capacity. And that's a very important notion when we think about the RB. Because for normal person, they are supposed to be here without doing anything. So when we decrease the inside of the alveolar pressure, with the alveolar pressure, they can go this way. They can have actually increased pulmonary venous pressure, or it's over-distended. They can go this way, and then over-distension can cause pulmonary venous pressure elevation. However, somebody with acute lung injury, they are typically here. So by increasing the pressure and by increasing the lung volume a little bit, to make sure they're not collapsing, actually they can come back to the lowest pulmonary venous pressure. So the positive pressure ventilation is not necessarily a bad thing for the RB. So again, the goal for the PEEP is returning endo-expiratory volume back to the FRC. And then what's interesting is Canada et al. Back in 1982 proved that PEEP actually increased PVR in normal lung, but PEEP decreased the PVR in acute lung injury. So going back to the scheme, it makes sense for normal people when they are here by increasing the PEEP and then by expanding the lung, they go this way, and then PVR actually goes up. But if you're here already, lungs are collapsing because of injury or pneumonia, whatever. By increasing the PEEP and then going back to here, you can potentially decrease the pulmonary venous pressure. So this is the animal study done by Canada et al. In the same study. So this is a normal lung, and then this is acute lung injury. When you, these are normal lung. This is a deep 0 PEEP, 5 PEEP, 10 PEEP, 15, 20. When PEEP is 0, it's low, but when PEEP is 5, it goes down and then it goes up as PEEP goes up. So lowest PVR was achieved at PEEP of 5. And then regarding this drop of PVR, it's unclear. This is done by animal study, and then they were not spine position. And also there is a ET tube in, so that might be affecting this drop. However, what I'm trying to say is PVR gets going up as PEEP goes up. And then in acute lung injury, in contrast though, when PEEP is 0, it's highest PVR. And then as PEEP goes up, it goes down. And eventually, it describes U-shaped curve. So apparently at the PEEP of 10, or maybe somewhere between 5 and 10, or even 15, PVR was lowest. So this is different between acute lung injury and normal lung. So now we know RV is not necessarily compromised by pressure. What we know is in normal lung or in relatively healthy lung, PEEP or positive pressure could increase the PVR. However, in the acute lung injury, PEEP or positive pressure actually could help to decrease the PVR. This is actually similar to protective lung ventilation. When we think about the lung protection, usually it's also protective for the RV. When you think about higher PEEP, lower tidal volume, it's actually protective to the lung as well as the protective to the RV. And then historical review of the acute cold pulmonary prevalence in the setting of ARDS actually decreased from 45% to 25% after protective lung ventilation was started. So this is before and after study. And before protective lung ventilation became popular, the prevalence of acute cold pulmonary was 45%, which is extremely high. And then we know if there is acute cold pulmonary or RV injury, it's associated with a higher mortality in the ARDS. But this actually decreased to 25% by doing protective lung ventilation. So based on this, I think protective lung ventilation or being adherent to the protective lung ventilation may actually help the RV. And then positive pressure ventilation is not always bad for the RV. So here, moving on to the LV lung interaction. This is a little bit different from RV and lung interaction. So this is a lung starting curve. I think this is very famous curve for the hemodynamics. And this is basically representing cardiac output. And this is a venous return curve. And you might have seen this in the Guyton's physiology. But basically, this crossing point, which is called equilibrium point, is the cardiac output. So in this case, this point is the cardiac output. I didn't put the number on the y-axis, but this is how with determining how much cardiac output is pumped out. So here, when we increase the intrathoracic pressure with a positive pressure ventilation, this cardiac output goes to the right. As a result, what happens is, when you think about this same volume in the body, venous return curve stays here. But because cardiac output curve goes to the right, your cardiac output drops here. On the other hand, if you decrease the intrathoracic pressure, cardiac output curve actually goes to the left. As a result, if your volume status is same, your cardiac output goes up. So this is a healthy person. When you think about heart failure people, they behave a little bit differently. So let's see normal people first. So let's say this is a normal cardiac output curve. And then you increase the intrathoracic pressure. Cardiac output curve goes right. And then your volume status is still the same. So initial cardiac output that you had is right here. However, by increasing the intrathoracic pressure, this cardiac output drops to here. And then the difference of stroke volume is quite big. However, if your cardiac output is already low and then patient is in heart failure, your cardiac output curve is like this. As a result, what happens is, even if you increase the intrathoracic pressure, it doesn't go down too much. So if you see the difference of delta stroke volume between normal people and heart failure, it gets smaller. So they're not affected by intrathoracic pressure change as much. So that's one thing to note, because it's important to understand why LV failure responds to the BiPAP or NPPV. So here, this is also animal study done by Dr. Pinsky in 1985. And as you can see, they gradually increased airway pressure. They gradually increased. And then they recorded how other hemodynamic parameter changes, especially with a special focus on LV. As you can see, as airway pressure increases, LV stroke volume actually goes up. And you wonder why, because stroke volume is supposed to be decreasing when you apply the positive pressure ventilation by shifting the cardiac output curve to the right. But there is a reason why. So when you increase the intrathoracic pressure, the transmural LV pressure actually decreases. As a result, LV afterload decreases. And then in contrast, when you decrease the intrathoracic pressure, transmural LV pressure increases, and then eventually LV afterload increases. So what happens is, when you increase the intrathoracic pressure, you're decreasing the LV afterload. When you are decreasing the intrathoracic pressure, you're increasing LV afterload. And just going back to the scheme. So when you're having this much drop of stroke volume, even if you decrease afterload, it doesn't affect the cardiac output as much. It's still dropping. However, when you're not having that much drop in the stroke volume, the reduction of afterload actually is way bigger effect than this. As a result, by applying the positive pressure ventilation, heart failure people can have actually higher cardiac output despite this drop. So going back, during positive pressure ventilation with higher PEEP or higher tidal volume, these pleural pressure, and that'll decrease the LV transmural pressure, because again, transmural pressure is the difference between inside of the LV, outside of the LV. So without tamponade physiology, it's usually difference between LV pressure and pleural pressure. As a result, that'll affect the LV afterload. So again, in normal heart, because of right shift of the cardiac output by decreasing the afterload. Okay, going back to the curve. Again, stroke volume drops by positive pressure ventilation, and then afterload reduce. So positive pressure ventilation is going to actually drop the cardiac output in the normal heart. However, even though stroke volumes goes down a little bit, afterload reduction is way bigger effect in the heart failure. So actually cardiac output increases in the heart failure population. The summary of the effect of PEEP on cardiac output in the setting of LV, well, with the focus on LV, LV, the PEEP actually decreases the cardiac output by reduction of the preload in normal people. But when PEEP is less than 5 or so, wedge pressure didn't change from no PEEP. And this is the reason why you could choose people 5 in normal people. It shouldn't affect the cardiac output even with the normal heart. However, when wedge pressure is high, with the because of the mechanism that I mentioned, PEEP actually can increase the cardiac output. And this is the reason why when we use an NPPV for the heart failure, they can actually have a higher cardiac output. Again, they might drop the stroke volume a little bit, but afterload reduction is way bigger effect for the people with a high wedge pressure and LV dysfunction. But this is the reason why positive pressure ventilation can help the LV dysfunction. So to better understand, again, when you apply the positive pressure ventilation, intrathoracic pressure goes up. As a result, what happens is, we know, let's assume lungs are normal for this patient. Venous return goes down because of positive pressure in intrathoracic space. And as a result, RV stroke volume goes down. On top of it, in normal lung, PVR goes up. And then RV stroke volume is dropping. Of course, LV preload is dropping. As a result, LV stroke volume drops. Even though we decrease the LV afterload, all right. So I'm going to wrap up the lecture very soon. So again, in the healthy person, assuming this patient has a healthy lung, elevated intrathoracic pressure going to cause drop in the venous return, also elevation of the PVR, venous register, so stroke volume RB, LB preload, because RB is not pumping out. LB preload goes down. So LB stroke volume goes down. Even though we're decreasing LV afterload, elevated intrathoracic pressure, the effect of this is not cardiac output drop. That happens in a healthy person, healthy heart person. On the other hand, if somebody has LV systolic dysfunction, let's assume what happens is intrathoracic pressure goes up, venous return goes down, PVR goes up. This is the same with the heart, and then right ventricular stroke volume goes down. Preload goes down. Same with the normal person, but what's different is LV afterload drops. This effect is tremendous for somebody with LV systolic. LV work significantly decrease, cardiac output increase. This is the reason why creation of somebody with heart failure. In summary, negative pressure ventilation applied, inspiration increases volume. On the other hand, positive pressure ventilation, inspiration decreases again, in regards to PEEP, PEEP increases venous resistance in the normal lung. However, it decreases the resistance in the pulmonary acute lung injury. So this tells us that when somebody has ARDS, PEEP is not necessary. You don't have to worry about RV. I think you should do your best for the lung. And that's probably the best for the RV. When PEEP is applied to somebody with a normal heart, in terms of LV function, cardiac output decreases. And when it's applied to the somebody with LV failure, cardiac output increases. This is the reason actually could LV dysfunction. This is a summary of my question. So I think you're right. Just going back to what often happens is when we intubate the patient in ED, let's say, and patient has low cardiac output, what happens is cardiac output are shift forward right, and when volume status is the same, volume drops to here, cardiac output decreases, blood pressure decreases. A lot of people try to come back to here, but to do that, because cardiac output is already low, what we can do is shifting this venous return curve to the right. This goes to this cardiac output comes back. A lot of people does it, but then what happens as a consequence is later on leaks to the eventually this makes a cardiogenic shift. So it's not directly related to the population, but when we are suspecting mixed shock plus cardiogenic shock, or when you are not really sure what type of shock patient has, actually I have very low threshold to do it. Figure this out. Your question is, I think, the reason why positive pressure ventilation can help in the setting of LV failure is really afterload. And the etiology of LV failure really, your question is, am I answering your question? Yeah, so this study, showing the was actually done in the patients with the elevated wedge pressure. So they don't talk about the systolic pressure, or systolic function. So even if it's a diastolic heart failure, if wedge pressure is high, maybe because of volume overload, it could be from diastolic dysfunction. But nonetheless, when wedge pressure is high, they are typically having an afterload reduction too. So I think it's probably the combination of both. But even with the diastolic dysfunction, yes, it did help the cardiac output. And then I'm not too sure what the exact mechanism of this. Afterload is one thing, but maybe applying PEEP to the alveoli is helping the alveolar pressure to stay open, and that's actually indirectly helping the RB as well. So personally, if there is a RB failure or acute cold pulmonale, I have a low threshold to start inotropes, but I will make sure ventilator setting is actually best for the lungs. Oftentimes, patient is on injurious, settings. For example, overinflation. If somebody has asthma or COPD, they might have auto PEEP, and then actually lungs may be overinflated. So the first step is probably making sure ventilatory setting is optimal for the patient's lung. Then, if RB failure still persists, I personally use inotropes.